Thank you, Ellie. And thank you, everyone, for joining us again this afternoon for another exciting session. This one is about new data on health equity. It's organized by Chris Krawczyk from the California Healthcare Access and Information Division. It's sponsored by Brilliant. And we're going to take just a second here. In just a second, we're going to invite Brilliant to give a few remarks. But I do want to call everyone's attention to the on-demand content, which is specifically dedicated to health equity and disparities. So if you haven't had a chance to watch some of those presentations that are in the on-demand section, I encourage you to do so. At this point, we're going to hear from Susan Clark from Brilliant.
Good afternoon. My name is Susan Clark, and I am a principal consultant for Brilliant, and I would like to welcome everyone to this afternoon's panel entitled New Data on Health Equity. In my role at Brilliant, I am privileged to consult with many state agencies, health information exchanges, managed care organizations, and many other aspects of the healthcare continuum. And endemic to all of those is the opportunity to address health equity from a data and analytics perspective. We are excited to sponsor this panel as it is such an important topic. Health inequities are really about preventable differences. Differences in the burden of disease, differences in injury, violence in different situations, differences in opportunities to achieve optimal health that are experienced by populations that have been disadvantaged by their social and economic status and environment. Many populations experience health disparities, including people from racial and ethnic minority groups, people with disabilities, women, and people in the LGBTQI community. I think we can all agree that our industry must improve health data collection and interoperability to improve health equity. Complete and accurate data collection is vital to understanding health inequities, measuring change, and evaluating system effects on individuals and populations. Today, the panel will discuss new data on health equity and walk through some studies and examples of utilizing this new data to improve upon and achieve better health equity. I am pleased to introduce the panel and your moderator for today's session, Chris Krawczyk, Chief Analytics Officer of HCAI. Chris will open up the panel and make some introductions on the topics and the rest of the panel. Thank you, Chris, and the rest of the panel from us here at Brilliant and the world of brilliant possibilities, and we look forward to listening in on today's session.
All right, thank you. And thanks to our sponsor, Brilliant, and thank you to Norman Donato for the conference and putting our session together today. I'm excited to be moderating this session on new data on health equity. We're going to have 3 presentations for this session, and we're going to go ahead and do a presentation and then take a pause, do a little bit of Q&A with the presenters for that topic, and then we'll move into the next presentation. And we'll make sure that we leave some time at the end to bring the full panel back up and do a Q&A with the entire audience and the entire panel. So please use chat, enter your questions in there, or feel free when we do the Q&A to unmute yourself and ask your questions in that manner. So our first presenters today are going to be Amy Kinner and Shari Maier. Amy is Senior Manager of Health Analytics at Onpoint Health Data, and Shari is a Health Policy Analyst at the Washington State Office of the Insurance Commissioner. They're going to be presenting their methodology and outcomes of a gender-affirming study, specifically study pertaining to the Gender Affirming Treatment Act in July of 2021 that was passed in Washington State. So without further ado, we'll go ahead and hand it over to Amy and to Shari.
Welcome, everyone, to our presentation regarding Washington's Gender Affirming Study. I'm Shari Maier with the Washington Office of the Insurance Commissioner, and I'm joined by Amy Kinner from Onpoint Health Data. Next slide, please. We'll start by talking about Washington State's Gender Affirming Treatment Act. So Washington Senate Bill 5313 provided further specifications regarding non-discrimination requirements for gender-affirming treatment. Advocates had indicated this was needed since many individuals were still experiencing issues getting gender-affirming treatment covered. For example, having categorical cosmetic exclusions applied. So the bill required by December 1st of this year, the OIC must report on the following: the number of providers offering gender affirming care in each county, the carriers and Medicaid managed care organizations with which these providers have active contracts, and the types of services provided by each provider in each region. So a little bit of background regarding how we decided to approach the report. So originally, we thought that carriers were going to be able to provide the information needed for the report. However, during rulemaking, it became quite clear that carriers do not have systems currently in place for tracking this information, since gender affirming treatment providers don't have a distinct type of licensure. So we ended up consulting with our state's healthcare authority and Department of Health about the potential for a provider survey. And in speaking with the State Department of Health, they let us know that for non-mandated surveys, they generally only see about a 35% completion rate. So we thought that might be a little bit low. So we considered whether we might want to use our state's all payer claims database as an alternative. So we kind of compared our two alternatives then. For the provider survey, again, we were going to potentially have a much smaller data set than we wanted, whereas the APCD could provide a fuller, larger data set. With the survey, there was the potential for errors and missing data, whereas the APCD was going to have a more complete and reliable set of data. The provider survey would actually cover all types of health insurance, whereas the APCD is a bit limited in its self-funded claims insurance. And the information available from the provider survey would be a little bit more current and also offer options for what they would do in the future, whereas the APCD was more retrospective based on claim submissions. So ultimately, we did decide to use the APCD because the pros of using it outweighed its cons, as well as the pros of using the provider survey, excuse me. The APCD, the main thing was that it had the larger and more complete and reliable set of data. So we will indicate in the report some of the limitations, such as the limited claims in the APCD for the self-funded plans. And I will hand it over to Amy now.
Thank you, Shari, for all that context and for your partnership on this project. I'm now going to dive into how we actually use the APCD to identify access to gender affirming care in Washington. And this was really a new use case for the APCD, so we had to be somewhat innovative. And as Shari mentioned, our key data source was the Washington APCD. We used medical claims data to identify people who had received transgender care in 2020 and 2021. We then worked with our excellent colleagues at the Healthcare Authority to identify a list of gender affirming procedures and drugs. And we also pulled the claims for those procedures for the most recent year, 2021, and used those claims to identify trans health providers and locations of those providers, as well as the carriers who pay for care. So I'm going to step through each of those steps now and give you a little bit more detail about how we actually did this study. So to recap, we used the Washington APCD. We limited to commercial and Medicaid plans, which was what the legislation required. So they did not ask for Medicare. And we used data from 2020 and 2021. Next slide. So we needed to identify our transgender patients because many of the procedures for gender affirming care may not be specific to the transgender population. For example, we want to include breast reconstruction for transgender patients, but not for women who have had breast cancer. So one way to do that is to limit entirely to transgender patients. But there wasn't a lot of information out there about the identification of transgender patients from the claims. But there was a study from 2016 published by Proctor and colleagues at CMS, which used Medicare claims to identify trans health patients in the claims, and then to validate that those patients truly were transgender using confirmatory diagnoses like hormone therapies and things like that to make sure that they truly were transgender. We then used the codes from the study, which were ICD-9 codes, since this was done with data before 2016, and mapped those to the appropriate ICD-10 codes. We then searched the claims to see if patients had 2 or more claims within 2 years. This is similar to logic used in the identification of various conditions from claims. And through this, we found about 0.3% of patients fit the criteria. We validated this against other information on the prevalence of transgender patients, and it seemed to be a reasonable percentage. And we know we're not capturing everybody because there are folks who probably didn't have services or diagnoses in the claims. So it's likely that the actual percentage is a bit higher. Next slide, please. The next step was to develop a list of gender affirming services to include in the study. The Washington Healthcare Authority provided us a list of procedure codes and pharmacy drug codes that the Medicaid program considers to be gender affirming care. And we looked at the full volume of claims billed for other procedures among transgender patients, just to make sure there weren't other codes that we were missing. And then our experts from our work group bucketed those claims into 6 categories: office visits, behavioral health, surgery, pharmacy and medical claims, diagnostic tests, and retail pharmacy. For office visits and behavioral health, those services were not particularly specific, so we required a trans health diagnosis to be on each claim that we included in the study to make sure we were truly limiting to providers who were trying to do gender affirming care. For surgery, though, for example, procedures were more specific, and we did not require a trans health diagnosis on the claim. We simply required that the patient already be identified as transgender in our earlier work. Next slide, please. So once we had our list of procedures, we went back and pulled the claims for our patients. We limited to transgender patients, extracted all of their claims for trans health procedures, and then used those claims to identify the providers and location of care. We also used those claims to identify what carrier paid for the care and what product, Medicaid or commercial, that carrier was providing. We are in the process now of putting this all together for the required reporting to the legislature. And that report is scheduled to be released by December 1st. So please stay tuned. We will have more results in the next couple months. And this report will be out there in the world in December. So we're looking forward to that. Next slide, please. Please let us know if you have any questions. Our contact information is here, and appreciate the opportunity to present this today. Thank you.
All right. Thank you, Shari and Amy. And again, if you'd like to ask Shari and Amy a question, please go ahead and put it into the chat. But in the meantime, I'll go ahead and I'll get us started. So just curious, how's Washington State going to plan on distributing and using this information?
Yeah, so the report is going to be shared with the legislature, and it is also going to be posted on our agency's internet website. So it'll be out there for people to, the public can view it out there. And the findings of the report, could potentially be used to help guide some considerations for improving access to gender affirming treatment in the future. Yet to be seen. So.
Excellent. What do you know the timing on the report and when that might be available?
Yeah, so the report is due December 1 to the legislature. So we are hoping to have it out right around that time. So
okay, excellent. So very soon here, coming up.
Yeah, right around the bend.
Excellent. And then my second question, I think this is probably for Amy. If I understood right, and I think it was slide 12, the goal here was to identify providers, but the same methodology could be used to identify patients, right? And and then like study patterns of care and treatment for transgender patients.
Yeah, I think so. This project that we worked on was very specific use case. We were trying to provide this information for the legislature. So we were very focused on getting the numbers of providers and where they're located and what carriers paid for care. But we could take, now we have a kind of a methodology for identifying gender affirming treatment claims, identifying those patients, and we could use that to look at all sorts of other aspects of gender affirming care and access and how folks are treated.
Okay. And let's see, I have a message here that came through. So there's a question, is there any possibility of using the data or the report to help understanding effectiveness, like which patients to treat gender affirming therapy and which not?
Shari, do you have any thoughts on that?
I mean, the report is mostly focused on just, which, where providers are at and, who, which carriers and Medicaid MCOs they contract with and the types of services being provided. So I think that could be something for further exploration. I'm not sure if what this report includes would get directly at understanding the effectiveness of treatments.
Okay.
I don't know. Do you have any other thoughts, Amy, about that?
Yeah, I would say this use case for this particular report doesn't really look at effectiveness. We're looking at how many patients, it's really going to say how many patients were treated, what are sort of the demographics in terms of age and geography, where people lived, where they received care, and what types of providers they saw. So we haven't gotten to that, but perhaps that's something we could do with a similar framework in the future, looking at effectiveness.
Okay, thank you. And we did just get a question entered into chat from Sylvia Hobbs. So we'll make this the last question for this part of the panel, and we'll get into our second presentation. But from Sylvia, do you do any QA of the APCD to determine inconsistencies in how the providers in the claims data reported gender after gender reaffirming surgery, as opposed to how gender was reported in the member eligibility data, and whether there was a high use of unknown in either the medical claims or member eligibility? Perhaps Amy first.
Yeah, that's a great question, and something that as we started, as I mentioned, we did some breakouts on age and actually did not do any breakouts on gender because it was unclear, what gender folks would be reporting, if they would be reporting the gender that they were, feeling they were transitioning to or prior. So we didn't look at that, but this could be something to look at in the future, to try to see how things are reported in eligibility data.
Okay. Thanks, Amy. So I think we'll go ahead and we'll go to our second presentation. Again, thanks you to Shari and Amy. Our second presentation is coming from Sharon Ulery with Human Services Research Institute, where Sharon is a research analyst. Her presentation is going to be best practices in gender identity data collection.
Hi, my name is Sharon Ulery. I'm a research analyst on the population health team at HCAI. We are a nonprofit that builds data systems to collect, analyze, and report healthcare data to improve the quality of health information available for research, policy, and practice. Prior to this job, I gained additional experience working with gender minorities at Fenway Health, the preeminent center for transgender healthcare in New England and arguably the US. I'm going to talk to you today about best practices in collecting and using data on sex and gender, which is a longtime passion and occasional frustration for me. I'll begin by talking about some vocabulary just to make sure we're all on the same page. Then I'm going to talk about why this matters so much to me and should matter to you. Then I'll talk about what I would love to see in an ideal world and what we have in the existing world. To start with, I'm going to be talking about transgender and cisgender people. So transgender people are people who see themselves and live their lives as a different gender than they were understood to be when they were born. Cisgender people are folks who live their lives and understand themselves to be the same gender as they were assigned at birth. I use identity-first language to talk about people. So if I say, for example, a transgender man, I'm talking about somebody who lives their life as a man and was assigned female at birth. Among trans people, there are trans men, trans women, and there are non-binary people who are a category of trans people that don't identify as men or women. It's important to note that transgender and cisgender have nothing to do with sexual orientation. For example, there could be a gay cis person or straight trans person or any number of other combinations. When we collect and report on data by gender without taking into account gender minorities, our analyses are inherently inaccurate as well as incomplete. If we look at only a single, poorly defined gender value, we can't determine which individuals should be receiving which services. Gender minorities face a myriad of health disparities, which we can only fix if we can measure them. And even as we collect more data points, a lack of cultural competency in the design can severely limit their use. For example, it's common for measures that try to recognize trans people to ask individuals to choose from a list of genders, beginning with man, woman, trans woman, etc. But of course, trans men are men. When respondents fit into multiple categories equally well, data is unlikely to be consistent and thus reliable. So, what would I love to see in an ideal world if I could wave a wand and make this work the way I was hoping? Well, one great place to start is this example from the Oregon Health Authority. They have spent a lot of time putting thought into how to ask very precise and relevant questions about sex and gender for different situations. As a research analyst, I would love to have every possible piece of data about every individual we're looking at, from sex at birth to current body parts to their own personal sense of gender identity, etc. For example, these can be relevant for healthcare because if you need to get your billing correct, you may need to know the patient's legal sex or the sex on their health insurance card. To do work with social determinants of health, you would need the patient's gender. And if you're trying to do preventative care, such as, for example, reaching out to everyone who needs a pap smear, it would be really great to have data on who has a cervix. That's relevant for trans women and cis women as well, because you don't want to include people who were born without a cervix or had a hysterectomy and had it removed.
Of course, as a worker with APCDs, as most of us in this room are, we don't really want every piece of information. Instead, we want to get the maximum information with the minimum data collection burden. In order to achieve that, it's important for field definitions to be as precise as possible and for demographic data to be consistent over time when possible. Sex assigned at birth is the best measure of biological sex rather than the mishmash of definitions currently submitted as administrative sex. Research backs this up. For example, Lombardi and Bannock found success in 2016 using the two-step measure shown on the right. They and other researchers have found that this preserves data accuracy across both transgender and cisgender populations. It allows for detail and precision for gender minorities, even with fairly complicated gender identities. And it shows a high degree of cultural competency where both trans and cis people are comfortable with the questions, understand them, and happy to answer them in good faith.
Okay, so if that's what the research shows, what are the barriers to getting that into our data sets? Well, there are a wide variety of infrastructure barriers. You can see on this slide that we go from having individuals who have a whole complex understanding of their own gender down to what we're actually collecting in the CDL, which is a single field with one of three values, M, F, or U for unknown. But I want to focus on two particular barriers. One is what we tend to record in electronic health records. There are a variety of strategies to collect sex and gender there, and EHRs do at this point they are required to have two different fields for that. One of the most common standards for collecting data in EHRs is HL7, and I'll be talking on a future slide about ways that I would like to see that improved. And the other, even more immediate barrier that I want to talk about is the X12 and CDL standards. So CDL currently is defined to match X12. On both, there are ongoing discussions about changing the standard, which I'm involved in. But at this moment, there is a single field available for sex and gender in both standards. And of course, even if we were able to change the values with a single single field, there's a substantially limited amount of information that can be communicated. So, assuming we manage to get a way to capture 2 fields for this, my proposal for what those 2 fields should be in particular is on the right of your screen right now. This is closely aligned with the proposal by Lombardi and Bannock, which I showed a few slides ago. There are 2 main differences. For the gender options, I've added a category for transgender not otherwise known. This is obviously not a self-identification category, but it's important for backwards compatibility. And then for the sex assigned at birth category, I've added a category for X. Right now, that's very rare, but as states are increasingly moving toward allowing a non-binary marker on birth certificates, we will have an increasing population of infants and children who have a non-binary sex assigned at birth. And on the left of your screen, you can see how we would convert the data that we already have with, for example, the HL7 mapping, the HL7 standard, how we would map this to this proposal so that we can take the data we already have now and send it through these 2 categories. And now I'd like to talk about some tips and tricks for doing research on gender minorities with the data that we have right now today. So in my preliminary research across a few states we work with, I have found that it's pretty safe to look at what gender a person has consistently at the beginning of the period you collect data on them and what they have in their most recent data. And if there have been any changes in the person's gender across the time you have data for, those 2 values are likely to be different. We generally do not see really messy gender data. It's more like M, confusion for a month or 2, F, or vice versa. Anecdotally, it's likely that that reflects a change in legal ID. It's important, though, to know that you cannot rely on a change in that field to identify trans members. There are transgender people who have been living as their identified gender for years before we started collecting data on them, and whose data, therefore, consistently shows their identified gender. And there are trans people who never changed their legal ID, and our data consistently shows their sex assigned at birth. So other ways to identify trans folks are looking for some procedure, billing, and diagnosis codes, such as those shown on the right of the screen. I'd like to leave you with 2 resources that have been invaluable to me in how I think about this topic and why it matters. And now I would love to take questions.
All right, thank you, Sharon, for the presentation. Again, if anybody wants to ask Sharon a question, please feel free to go ahead and enter that into chat, and I'll be monitoring that. But in the meantime, you showed how to map collected gender identity data into the standard that you propose. Could you expand a little bit more on the advantages of this approach?
Of course, thank you for the question. So there are currently competing standards for collecting gender identity data, but the HL7 standard is the most common one proposed by current day experts. However, experts that advocate for those response options typically intend for it to be a choose all that apply question. Given the limitations of our infrastructure, it's most often been implemented or proposed in a claims context as a choose one. A lot of individuals fall into more than one category. In particular, trans men and women are, by definition, men and women, respectively. So when it's implemented as a choose one, there's a built-in assumption that people who respond woman or man are cisgender, which both stigmatizes trans identities and leads to inaccurate data. There hasn't been a lot of research on how gender minorities respond to these questions, but not all trans people closely identify with the term transgender. And anecdotally, I've seen a significant number of cases where a person's sex at birth doesn't align with their response to this framing of the question. So the goal with this new standard is both to collect additional data on sex at birth when that's not implied by the gender identity, and also to allow for less overlap between the categories we're collecting.
Excellent. Thank you, Sharon. And we did receive a question from Ben Hochschild. Ben's asking, how are the provider questions on anatomy, for example, do you have a uterus, et cetera, how are they used to identify gender? Would there be a way to distinguish between a transgender woman who's had gender confirmation surgery and a cisgender woman who had undergone a hysterectomy?
So to answer the detailed question there, we do not have the science to construct a uterus. So someone who has a uterus was assigned female at birth. Someone who doesn't have a uterus, it's not known. More broadly, they wouldn't be used to identify gender in the sense of gender identity and social determinants of health. They can be used to identify people who are transgender if they have a set of body parts that is not phenotypically common. And they can be used for a bunch of quality assessments or preventative health measures, the kinds of things where what you need to know is, does this health procedure make sense for this person, regardless of their sex or gender?
Okay, and Ben did add a clarification into the chat. Sorry, transgender women, regardless of gender confirmation surgery. So thank you, Ben, for the question, and thank you, Sharon. Really quickly, we do have time for one more question that came to me via a separate chat. Have you looked at the correlation of ICD-10 F64 diagnoses with other methods of identification?
I have looked a little. I don't have anything conclusive. I can speak anecdotally and say that there are a lot of people whose sex marker has changed over time that do not have one of the F64 diagnoses. And I think a smaller number, from what I've seen so far, of people with the F64 diagnosis where their gender has not changed over time. I've also looked at how it correlates with bottom surgery, and pretty much everyone getting bottom surgery has one of the F64 diagnoses if it's bottom surgery billed as such, rather than as individual procedures. But that population is very small and is only a small percentage of the people with the F64 diagnosis.
Okay.
So basically, none of these methods work by themselves. You have to come back.
Yes. All right. Thank you, Sharon. And we'll have time at the end if anybody has any additional questions for Sharon, but we'll go ahead and move into our third presentation, which is going to be given by Rexford Anson-Dwamena and Priya Pattath, and they're from the Virginia Department of Health, and they're going to be presenting on maternal care deserts and low birth outcomes.
Good afternoon. My name is Rexford Anson-Dwamena, and I'm here this afternoon with my partner, Priya Pattath. We are here to share with you a study that we have done in Virginia, and we hope that we'll be able to let you know what we have done in Virginia and also learn from you. The objective of the study that we performed in Virginia was to determine or to explore the determinants of low birth weight at a very granular level, which is, we call it a neighborhood level, census tract level, as well as the access to maternal care and also availability of care, and as well as the social demographic factors in those areas. We are fortunate in Virginia to have a very big data set. So we use 2016 to 2021 data set from various statistics. We also considered the maternal care, prenatal care, mother's education, race and ethnicity, rural and urban, as well as the level of access to OBGYN. Now we also show you how we define what a maternal care desert is by using these three categories. We look at the threshold of 30 minutes drive, the poverty level, 2 FPL, and also if the area is health professional shortage area. First, we calculated the distance of the mother's from the mother's census tract to the nearest OBGYN facility. We then calculated pulled the data from census to look at the federal poverty level, and also if the area is a HCAI designated. We use these three variables to construct an index, and based on that index, we're able to designate which area is a desert in the state. When defining these areas as a desert, or access to maternal care or limited access to maternal care, we then block the data with the low birth weight to look at the percent of low birth weight in these three areas that we have designated. And lastly, we model the data using what we call chi-square automatic interaction detective analysis to tease out which type of population that we should be targeting. The map you see here shows you the level of access to maternal care. You look at the yellow areas, that shows you access to maternal care. The second area is the orange area, shows you the limited access to maternal care. And the red areas are areas that are designated as maternal care desert. And like I said earlier, for an area to become a desert, you have to travel over 30 minutes drive. Also, the population in that area has over 20% of poverty level, and also the area is designated by the federal government as a shortage area. Now, to account for mothers who went outside the state, Virginia is bordered with so many states, about 6 states. We also did what we call edge effect to account for these mothers who had their babies outside the state, so that we control for that to be able to get accurate distance travel by these mothers. Now, here are the results. Now, if you look at this graph you see here, mothers that live in access to care, good access to care areas, maternal care areas, traveled on average of 16.5 minutes. Those who lived in limited access to maternal care traveled 37.2 minutes to get OBGYN services. And those who live in the desert areas traveled 46.6 minutes to have access to OBGYN. Now, the surprising thing here is that you see those who live in the desert area almost travel 3 times distance compared to those who live in access to maternal care. Now, based on that, we also look at the low birth weight. So we combine the mothers who live in the desert with those who live in limited to maternal access, with those who live in access to maternal care, and realize that those who live in the desert and limited areas had a 6.8% of low birth weight compared to those who live in the access to maternal care with 8.1% of low birth weight. Now, modeling the data using the chi-square I said earlier, the idea here was to tease out which population should we be targeting for an intervention. Now, when you model the data for areas that has a low birth weight compared to those that had a normal birth weight, you can see that low birth weight in the state was 8.1%. But number one predictor of the low birth weight was the prenatal care. And under the prenatal care, those who had adequate prenatal care, education became the second predictor. And based on the second predictor, we also had the mothers that had a high school or below as another education being a second predictor, high school or below, access to level of access, which is those who live in a desert area, within these areas, had a 10.1% of low birth weight. Now, the result here is that if you look at those who live in the desert area and they had a low education, had almost 10.1% compared to the state with 8.1%. So that shows that if Virginia were to target any population to have any or to address this issue, we need to target those who live in the desert areas and had a low education. Conclusion: this analysis is prompted us to look into access to maternal care in Virginia, especially the rural areas, and also we are able to work with the primary care office to incentivize providers to work in these underserved areas so that we can address some of these challenges that these mothers are facing in these rural areas.
All right. Thank you, Rexford, and thank you, Priya. Again, if anybody wants to ask Rexford and Priya questions, please go ahead and enter it into chat. In the meantime, Rexford, I don't think I caught it. You may have said it, but what software did you use to determine the maternity care deserts?
Actually, we use GIS as a Geographical Information Systems, GIS, and then look at the road network. So we didn't use as crow flies. We use the network because the rural areas have some mountains, and so we use that to calculate the distance from where the mother lives and the next the OB/GYN center. So we use software
Okay.
GIS to do that. Yeah.
And it was actual drive distance, not, as
Yes,
you said again, not as a bird would fly. Okay.
Exactly. Yeah.
And what were the underlying data sources?
Well, Virginia does a very pretty good job in collecting data, vital statistics data. So we have all the birth data, birth and death data, and also we use census ACS data to compute the poverty data. And then HESA has their own designation data that we pull from their website to show us areas that are classified as a HIPSA. So we use all these three data sources to actually come out with this definition.
Okay, excellent, thank you. I'm not seeing any other questions in chat, so we do have sufficient amount of time to bring the entire panel back up and do some panel Q&A. So here we go with Sharon and Amy and Shari. Welcome back. Again, if you have a question for the entire panel, please go ahead and put it into chat. I'll go ahead and I'll just maybe get us started. We had, two of our presentations, focused on transgender, and then one of the presentations with a focus on mothers. Maybe if you can each talk a little bit about how you see all of the these three topics, these three presentations fitting together. And I think maybe Sharon, I'll start with you. I'm trying to figure out how to navigate this, but we'll go ahead and we'll start with Sharon, and then maybe go to Amy and Shari, and then if Rexford and Priya have any comments.
Sure. I think for me, all three presentations illustrate the importance of collecting accurate information about sex and gender. Amy and Shari, I think, noted that their work would have benefited by being able to look at people by gender, and perhaps compare the accessibility of services for transgender men versus women versus non-binary people if we had reliable data on that. And more broadly, I think people sometimes look at efforts to clarify sex and gender data as a niche goal that only affects trans people. But if we're going to report data by gender, like we are sort of inherently doing when we talk about maternal health, we need to know what we're reporting on. So for example, if we collected more of this gender data, we would have been able to look at whether gender identity is one of the social determinants of health that affects the quality of care received by laboring parents. And this is sort of further afield from their research, but we'd also be able to get more precise measures of how many people become and stay pregnant out of the most accurate population, the population of people with the body parts to carry a pregnancy, rather than people marked F in our data.
Okay, great. Thanks, Sharon. Amy, Shari, anything to add?
Yeah, I would just add, I saw some kind of overlap with Rexford and Priya's presentation in terms of access to care and drive time. And we've been kind of looking a little bit at anecdotally, we know some people can't get care in Washington State and are going to other states like California and Arizona for care. So looking a little bit at, where in the state do people, and we also saw I think we're probably going to, when we put out the reports, we have seen that a lot of people seem to be traveling to King County, where Seattle is, where there's probably more providers. So that type of perspective that they looked at drive time would be really interesting to do with the data that we have as well. We haven't gotten there yet, but just looking at where there are gaps in care.
Thanks, Amy. Shari, Rexford, Priya, anything to add or go on to the next question?
Well, I think what I've learned so far is Priya and I work in Office of Health Equity, and we have not been able to do much work on transgender. So this is an eye opener for me in person. So I think I like what my colleagues presented, and I took some notes. So we do also have very extensive and comprehensive APCD data. So probably will reach out to them later on to see if I can get some advice from them how to go by, what they did, because I would like to do the same thing here in Virginia.
Excellent. Thank you, Rexford. And the first presentation with Amy and Shari, they identified, that there were limitations in other data sources, and then, the move to using the APCD, and then, Sharon and again use the APCD, and now Rex indicating potential opportunity there. But what are some other data sources, or what are sort of, this session is kind of called New Data on Health Equity, right? Health information exchange, does that present an opportunity, or transformation? Just what are some other opportunities to get data for transgender, or even studying the maternal health islands and deserts?
Well, I think I will speak with. Virginia. I don't know about other states, but we do have very good data collection methodology. So when it comes to vital statistics data, birth and death, we have a very good data set. So that was not the issue for us. The issue for us was the expertise to actually do the analysis, because we were looking through this. That there were questions in Virginia that some of these mothers were traveling from rural areas to the cities, bypassing the nearest OBGYN centers. Well, the question is that they were bypassing before the closure. So the analysis showed us that these mothers were actually bypassing these areas. So we have learned so much from this analysis. It's not comprehensive yet. Priya and I will look into it again and see how best we can modify the research and probably do some publications.
I would like to add that from based on the panel presentation here, like it just emphasizes the importance of looking at minorities and especially transgender, and also and linking that with the social determinants of health. For example, here we found the major the variable which had an impact was the mother's education, and I think that like using APCD or any other data source, linking that with transgender or with any other minority population, SDOH is one important factor. That's what I found from our analysis and also from the discussion over here.
I think I wish for data from EHRs for a lot of different analyses, but I think that would have been useful for all of these sets of research. And I talked very briefly about the infrastructure barriers to obtaining that.
Mm-hmm. Okay, and we do have a question from Sylvia Hobbs in the chat. So focusing on QA again. So when QA is conducted of the gender field in health data systems, a traditional metric to detect so-called errors in the gender field is if the patient has a diagnosis code of pregnancy and gender of male. What health data QA metrics would you recommend for the gender field?
So my immediate thought upon reading this question is, what is the goal of the QA? If the intention is to figure out whether we should pay for this procedure, or if the intention is to figure out whether broadly at a population level we're giving good care, those are two really different goals and going to have different answers to the question. To the extent that I can answer without that, I think you can sort of treat a gender of male as take a second look and look to see whether that person has, say, received pap smears in the past, or other things that indicate that it's not a one-off.
Okay. Amy, Shari, others? All right. Not seeing any other questions from the audience here. So I'll go ahead and maybe queue one up. Let me see here. So coming back to the quality, Sharon, you kind of said that it was hard to answer the question without knowing both, or what was the overall objective. Do you maybe want to answer the QA question for both objectives? Because I am seeing a little bit of interest here that QA is a particular, it's always an item of importance, right? Getting quality data in. A number of the presentations did talk about the limitations of incomplete data, or how the data is collected, and the data not being complete or not being high quality. So sticking with this theme of QA, maybe do you want to take both scenarios, both objectives that you identified, and maybe go a little bit deeper into those?
I can try.
Okay.
I will say that my bias coming into this is having heard a lot of stories about people having difficulty getting their care covered, and not a lot of stories of how terrible it is that somebody marked male, submitted data, or submitted a claim for a pregnancy. So there's my caveat going into this. My first inclination is that doesn't sound like an error. Find something that's a real error to QA. But on a population level, you can do checks for like the percentage of time this is happening. That's what Amy and Shari did to see how strong their checks for trans people was by comparing what is the overall population, and if you're getting an overall number of male pregnant people who are in line with the number of trans people or trans men in the population, that's a good sign. If you're getting twice that, then you probably have data errors to work with. On a more one-on-one level, like claim adjudication, I think you really do, with the data we have, you really do have to go back and look at what previous claims have been submitted. If somebody's been getting prenatal care for months, then that's probably real. If there's a single submission for one pregnancy related thing and then it goes back to nothing related to that, that was probably a data entry error. But the real solution is to collect more data. If we start collecting both sex and gender identity on every claim, then the question goes away, because anyone with sex assigned at birth of female can be pregnant, and you don't need to look at the gender identity at all.
Mm-hmm. Thank you, Sharon. Amy, Shari, anything you want to add before I go to Rexford and Priya with a separate data quality question specific to their presentation? But anything for you to add, Amy and Shari?
I don't have much more to add on this. I think Sharon sort of explained this well. It's not, I don't think we imagine that there's huge issues with lots of bad data on gender.
Okay. All right, thank you. And so Rexford and Priya, kind of sticking with, again, the interest in data quality here. And, when you're looking at deserts, we've been doing some similar analyses in California, urban, rural, frontier, looking at distances and so on. And generally, like as you get to more frontier, the address information, a billing address is more common than a residential address, or the address on record could be a PO box. And so, those distances and the potential for an error in measuring those distances as you get to a more rural or frontier region increases. What are your thoughts, challenges, opportunities, and sort of how to address, those potential biases?
Well, we have few of them, but I think about 1% of the data that we collected had an issue with the addresses. So what we did is that but we did have the zip code because of the billing. So we went to we did what they call crosswalk from zip code to sector. Did the proportion just to smooth out the data and display. So that was and then because we also did The distance, we didn't do geographical distance, we did population weighted distance. So actually, I had actually some where people were living, not just where the center of the census tract is, but where people live, where people are. So the issue of quality was not big deal for us in Virginia because 1% was, I think was manageable, and because we were able to crosswalk them from zip code to census tract, that was resolved. So
Okay.
there wasn't much problem for us.
All right. Thank you. So I think I've gone through the questions that have been asked. Again, I want to thank our presenters and those that submitted questions today. Also want to thank our sponsor, Brilliant, and again want to acknowledge and appreciate Nato and Norman Charles and all the work that they do putting the conference together each year. Thank you all for attending our session today, and wish everyone well and that everyone enjoys the remaining time at the conference. So thank you and have a great day.
Thank you.
Norman, back to you.
Thank you.